Good afternoon, everyone. Thank you all for joining us on Zoom today. Just a few reminders before we begin. If you're a member of the advisory committees, please accept the invitation to join as a panelist and mute your microphone. Remember to raise your hand or turn on your microphone when you're ready to speak, and mute your microphone again when you have stopped speaking. It looks like we have most people who will be attending now. So we'll go ahead and get started with this meeting. This meeting is being recorded. It doesn't do that because it's already recording. The recording will be posted on the advisory committee's webpage shortly after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. I would like to welcome all advisory committee members. Thank you so much for joining us today. It is now 3:03, and I call the June 12th joint meeting of the Advisory Committee on Data Issues and the Advisory Committee of Healthcare Stakeholders to order. My name is Rochelle Bogue. I am the Cost of Transparency Manager, and I would like to welcome everyone joining us today. First, we'll start with a brief overview of the agenda. We'll begin with roll call. Then we will approve the March 7th joint meeting summary. Next, we will hear from Liz from HMA, who will provide us with a review of the May cost board meeting and an overview of the 2024 work plan. After that, we'll hear from Joe Dealman from IHME, who will present on the Analytics Support Initiative Disease Expenditure Report. Then Sheriel from Healthcare Authority will give us an update on the provider reporting and methodologies. We will then have public comment. Finally, we will wrap up and adjourn today's joint meeting. I encourage committee members to ask questions and provide feedback to help facilitate our discussion and recommendations to the cost board. Thank you all again for your time and efforts. But before we get started, I would also like to welcome new staff members who will be overseeing these two committees moving forward. So let me introduce you to Hope Kilman. I'm so sorry. Kilborn,
You got the first part right.
who will be facilitating the stakeholder committee meetings moving forward. And this is Marty Ross, who will be leading the data issues advisory committee meetings moving forward. I would also like to give a warm welcome to our two new chairs for these committees. First up, for the Healthcare Stakeholder Advisory Committee, we have Chair Eileen Cody. And rather than me just reading her bio, I was thinking, Eileen, maybe you could just say a few words and give a little bit of information about yourself. Oh, I think you're on mute.
Yeah, I got it.
There you go.
I don't think there's much to add to this, and there's a lot. I've been around long enough that a lot of people already know me, and I'm glad to be participating, and we'll hopefully get everything moving forward so we can start controlling some of our healthcare costs.
Thank you, Eileen. We're glad to have you. And Bianca Frogner, would you like to introduce yourself and say a few words?
Hi. Yeah, sure. And I'm sorry, I'm actually kind of in a noisy spot at the moment that I have to move out of, so I apologize. But I'm Bianca Frogner. I'm a faculty member at University of Washington in the Department of Family Medicine, and I direct the Center for Health Workforce Studies and the Primary Care Innovation Lab. And so I do a lot of health workforce research, and I sit on the Healthcare Cost Transparency Board. So all the things that are on there on the slide, but I work a lot with data, so I'm excited to kind of work with a team to think about data issues in the state.
Thank you, Bianca. We're happy to have both you guys. Now we'll go through member roll call. I will call members by first name in the order listed on the agenda, which is in alphabetical order by last name. But we would also like to use this opportunity to allow members to get to know each other a little more. So when I call on you, please unmute your microphone and let us know that you're here. And also, where is your favorite vacation destination? And then please mute your microphone again. We will start with the members for the Advisory Committee on Data Issues. Krista.
Good afternoon, everybody. I'm here, and my favorite destination, probably Germany, where my family is from.
Have fun. Thank you, Krista. Megan?
Hi, I'm Megan Atkinson. I'm the Healthcare Authority's Chief Financial Officer. I'm happy to be here. And my favorite vacation spot is anywhere that is on a beach.
Oh yeah, that sounds nice. Thank you, Megan. Amanda?
Hey, Amanda's here, Amanda Avalos, Healthcare Authority Deputy for Enterprise Analytics. And I've had some great summer trips to Leavenworth, Washington, so.
Oh, I love Leavenworth. Thank you, Amanda. Jonathan?
Yeah, good afternoon. Jonathan Bennett from the Washington State Hospital Association. I'd say it's tough to beat Hawaii.
Yeah, that's true. Thank you, Jonathan. Bruce? Bruce, are you with us? Jason?
Afternoon, everyone. Jason Brown, Office of Financial Management, Budget Advisor to the Governor for Low Income Health. Thank you for having me today. Favorite place to vacation? I mean, I gotta say Scotland. It's just a fun people and a beautiful country.
That's a good answer. Thank you, Jason. Chandra?
Oh, hi, Chandra Hicks. I'm here. My favorite vacation destination is visiting my grandma in Chicago.
Thank you. Leah?
Good afternoon, Leah Hull Marshall from the Health Benefit Exchange, she, her pronouns. Maybe not a favorite, but a recent memorable one is we went to Kentucky to see the Kentucky Derby, which was really a fun, unique experience for our family.
That would be a fun, unique experience. Thank you. Lee Chow?
Hi, this is Lee Charlie with OIC. I'm the chief actuary with OIC. My favorite vacation is Taiwan, where I get to see my family and friends.
Thank you. David?
Yeah, David Mancuso with DSHS Research and Data Analysis. I was going to go Scotland, but I feel like that's taken. I'll go with Orcas Island.
Oh, that's a good one too. Anna?
Hi, everyone. I'm Anna Morales with United Healthcare. My favorite destination spot is the Cayman Islands.
Thank you. Hunter?
Hi, Hunter Plumer with Health Trends, and favorite vacation spot is Grace.
Great. So I would love to go there. Thank you. Mark?
Hi, good afternoon, everyone. Mark Pregler. I'm Director of Data Management Analytics with Washington Health Alliance. Favorite destination is really any nice hiking trail out in the mountains.
Thank you. Russ?
Hi, good afternoon. I'm Russ Schust. I'm the Senior Director of Medical Economics at Optum. My wife and I have been vacationing through an app called Harvest Host, where we camp, and we love it. And so we've just been exploring Washington State. It's so beautiful here.
What was the name of the app?
Harvest Host.
Okay, I'm going to
It's
try to
for
remember
camping.
that.
Yeah.
Thank you.
You're welcome.
Mandy? Mandy? Julie? Julie? Okay, now I will turn to the Advisory Committee of Healthcare Stakeholders. Emily? Patrick?
Hi, Patrick Connor with NFIB. Somebody already said Hawaii, but maybe be more specific, Maui, although I usually get outvoted, and the family favorite is Paris.
Paris, that's a good one. Thank you, Patrick. Bob? Paul F? Justin?
Hi, everyone. Justin Gill, President of the Washington State Nurses Association, and currently practices as a nurse practitioner in urgent care. Favorite destination spot would have to be Tuscany, Italy. By far my favorite.
Thank you, Justin. Next is Nariman, but I was notified that Dr. Nariman Shmati will not be joining us today. So Adrian?
Hi, Adrian Jones, she, her pronouns. I am a graduate student at the Evans School of Public Policy and Governance at the University of Washington. And my favorite vacation place is Whistler, British Columbia.
Thank you, Adrian. Jody?
Hi, I'm Jody Joyce. I'm the CEO at Unity Care Northwest in Bellingham, Washington, which is a community health center. And I'm a representative of the Washington Association of Community Health. I have a three-way tie for my favorite destinations: Siena, Assisi, and Venice, Italy.
Great, thank you. Luis? Stacy? Eric?
Hello, I'm Eric Lewis. I'm the CFO at Washington State Hospital Association, and I think my favorite place to vacation would be the Boundary Waters in Minnesota, canoeing with my son.
Fine, thank you, Eric. Vicky? Natalia?
Hi there, Natalia Martinez Kohler. I'm the CFO for MultiCare's Behavioral Health Network in South King Region, and I love Cannon Beach, Oregon.
Thank you, Natalia. Sulan?
Hello, it's Sulan Milnerik from SEIU 1199 Northwest. I use they, them pronouns. My favorite place to vacation, honestly, I'm trying to get out of vacationing in the summertime because it's actually the best here. So that would be my answer.
That's a good answer. Paul S.
Hi, everyone. I'm Paul Schultz. I'm Executive Director of Actuarial Services for Kaiser Permanente, Washington. My favorite vacation destination is Yoho National Park in British Columbia.
Thank you, Paul. Dorothy?
Hello, Dorothy Teeter. Glad to be here with all of you. I would say I'm going to have to join Justin in saying Tuscany, Italy.
Thank you, Dorothy. Wes?
Hi, Wes Waters, CFO for Molina Healthcare Washington. My wife and I like to spend time in Alaska, so it's our favorite place.
How fun. Thank you, Wes. And thank you so much for all your answers and for all of the committee members for participating in today's meeting. So please join me in turning to the second tab in your meeting packet. We will approve the meeting summary from the last joint meeting on March 7th. We will use the consensus process for a vote of the approval of the meeting summary since that was a joint committee meeting. Is there any discussion of the March 7th, 2024 meeting summary or proposed changes at this time? Is there a motion to approve the minutes?
This is Leah, so moved.
Thank you, Leah. Is there a second?
Second.
A second, this is Russ.
Thank you, Russ. All in favor, say aye.
Aye.
Any opposed? Okay, the motion is approved. The meeting summary for March 7th is approved. Now I will turn it over to Liz at Health Management Associates to lead us through the updates from the cost board meeting and the 2024 work plan.
Great, thanks, Rochelle. So great to hear about everybody's favorite places. Makes me excited to go somewhere soon. Just a quick orientation to where we are today relative to where we've been and what we're expecting for the rest of the year. Today, obviously, is the joint meeting of our two committees. The cost board met earlier this year with kind of a new focus on evaluating potential policies to address costs. And since then, there's been a couple of meetings focused on looking more in detail at those potential options. And at our last meeting, we talked specifically about what you all are considering in your separate meetings that are happening on either side of this joint meeting. But quickly, the goal, if we go to the next slide, really out of today, is over the course of the next few meetings for the cost board to be considering and going in depth into some of these policies and sending some of these questions to the various committees as they see fit. So if we go to the next slide, specifically, I'll just mention at the May cost board meeting, in addition to hearing from the Primary Care Advisory Committee and strategies that could help the state achieve the 12% goal on spending for that, we also heard about the findings from the analysis of the Washington hospital financials to understand a little bit more about hospitals, how hospitals are contributing to the growth of healthcare costs. And that analysis grouped hospitals into categories according to low, medium, high for price, profit, and cost. It was very informative. And we also got an update on the Analytics Support Initiative. So go to the next slide. This is specifically what after hearing about medical debt and facility fees and business oversight, the board has requested some support from both the data committee on medical debt, and I'm sorry, the stakeholder committee on medical debt, which we discussed just a little bit ago before this meeting, and then requested some support from the data committee specifically on facility fees and business oversight. So that's where the topics for today's meetings emerged from. And the hope is that these issues will get some more information that will go back to the board at the next meeting. So that is the update from May, and I'm going to turn it back over to Rochelle.
Thank you, Liz. Next, we'll hear from Joe Dealman from IHME, and he'll be presenting and leading discussion on a draft of the DEX report.
Great, thanks, thanks Rochelle, and thanks everyone. Thanks Chair Cody and Frogner. It's a pleasure to be able to present today. I am excited to be able to kind of talk about a preliminary report that the Analytical Support Initiative has put together. Go to the next slide. The impetus for this report is really stated here in this first bullet. A team that I lead at the Institute for Health Metrics and Evaluation has been working on a project for the last 4 years already, where we look at healthcare spending in the United States. The objective of the project is really to just understand where healthcare resources is coming from and where it's going to. It's primarily a descriptive analysis. The idea is that that project, I should say, was really finishing up at the same time that the Analytical Support Initiative was getting started. And we wanted to use some of the lessons learned or the data and estimates that were generated from that 4-year project to, provide information to the cost board and to the advisory committees. And so that really led to bullet point number 2 here, which is the creation of what we're calling a preliminary disease expenditure report. And so that is what I'm going to be presenting today. I presented that to the cost board last month, and excited to get your feedback and ideas and suggestions before we move forward with the cost board doing a final review of it. A couple of caveats just before we dive into what this preliminary report is this is extracting data and estimates from another project. So it's not tailored specifically to the initiatives and goals that the cost board is working on currently, although we feel like it does provide good context and some supporting evidence that can be used for the cost board and for the advisory committees. Yeah, with that, I think I can go on to the next slide. So today, the hope is to address these 2 questions. Feel very comfortable taking feedback and interruptions as I go, or we can also do the questions at the end. But, where we are with this preliminary report is we hope to have it approved and finalized in the next month. And so one of the primary questions is there fine tuning that we could do? Are there things that you, as the advisory committees, feel confusing or is unclear or could be, made better in a way that could inform both your work and the cost board's work? So that's kind of the fine tuning component, really things that could change in this preliminary report in the next month. And then the kind of bigger question is, as the Analytical Support Initiative kind of continues and begins to do kind of custom analytics that are specifically tailored to the cost board's policy priorities, are there ways that we can take what we've already done and make it more useful? So in some ways, it's the exact same question, but it's a different time horizon. The first question is, what can we do in the next month to make these estimates more useful to you and the cost board? And the second question is, how can we make these estimates more useful, but it's bigger in scope? It's not over just the next month, but really over the course of the next 8-9 months. Next slide. So a little bit about the disease expenditure project. That's the project that's after 4 years of work kind of coming to a close. It spans, when we started 4 years ago, the data that we could get, which was 2010 through 2019. So we recognize that it's already a little bit dated. And one of, just as an aside, one of the kind of first tasks of the Analytics Support Initiative is to take these national estimates and tailor them towards Washington and also update them through 2022. So that's the objective, is to add at least 3 years. There's data lags that really restrict us from going too much further. We know that even 2022 is, feels like distant history, but because of data lags, that's about as far as we can get. It is a very data-intensive project, and so for the national study, we pulled from over 60 billion insurance claims and over 1 billion administrative records from hospitals and emergency department visits. In the state of Washington, we're pulling from 550 million insurance claims and 30 million administrative visits to hospitals and emergency departments. So a lot of data feeds into this analysis. And the goal really is to, again, kind of understand where healthcare spending is coming from. Is it Medicare money? Is it Medicaid money? Is it private insurance? Is it out of pocket? And where is it going? Is it for patients who are, the Medicare population above 65, or is it pediatrics? Is it for oncology, or is it for mental health? Is it inpatient care, or is it outpatient care, nursing facility care, pharmaceutical care? Those are the sort of questions, that kind of descriptive analysis that the Disease Expenditure Project really intends to answer. And in doing that, we're really looking at where the spending is attributable. So, an example might be diabetes. What we're capturing is all the spending associated with someone who has diabetes, and the spending that is specifically on diabetes. So next slide. So getting into a few results, the full set of results and the full preliminary report are along with the booklet or the packet for today. And so you're welcome to take a look at it. I hope people maybe have had a chance to look at it. I'm just going to pull out some of the kind of primary findings that, again, I think provide useful context for understanding healthcare spending in the state of Washington. So this first figure is 2019 spending per capita, and it's a look at 50 US states and the District of Columbia. And there's two different colors here. The x-axis is really just spending per capita. So the bigger the bar, the more spending there is. And you can see the state of Washington is kind of in the middle of the pack. It ranks 16th lowest amount of spending if you look at per capita spending. And then one thing we do as researchers often is adjust for the size of the population and the age of the population. So Washington tends to have a population that looks mostly, as far as the age profile goes, mostly like the rest of the country. And so that age adjustment doesn't do a huge amount. You can see the lighter red for Washington is just a little bit bigger. That's because we have a slightly younger population than the rest of the country as a whole. But again, Washington falls as 16th lowest spending per capita. Next slide. So the next question we started to look at is who as far as age and sex is receiving or spending these resources? Who are the patients? And so the figure on the left looks at where the resources are going. And you can see that the biggest bars are for the age group that is 65 years through 69. So that's where more resources for healthcare in the state of Washington are going than any other age group. You can see very little of our resources is going to pediatrics, or the 0 to 19 or 0 to 15 categories on this figure. And you can see that in general, we spend more on females than males, and that's very typical. Part of that is cost of reproductive health, and some of that is because women live longer than. On the right, you can see, and I guess on the left, you can see really where that money is coming from. So, pre-65, most of the spending is private insurance with, not an insignificant amount that's out-of-pocket spending, and also Medicaid. And then above 65, you can see those blue bars. Medicare really takes over as of course, the main spending source. On the right is that same figure, but instead of looking at total resources spent, it looks at spending per capita. You can see that we spend the most on the oldest populations, and that is true pretty much across the lifespan, with less spending for younger patients, except for the very youngest. That first year of life is really expensive. Anyone who's had a kid in the last decade or so knows that the bills associated with that baby being born are really expensive. So you see a lot of inpatient care and outpatient care for infants. But as people age, they on average spend more per capita. And the green bar here really highlights that a lot of that spending is ambulatory care. So that's outpatient care. Next slide. So this is just a simple breakdown of where the money goes and where it comes from in the state of Washington. So in 2019, we estimate in our study that there was just over $51 billion of healthcare spending that is included. So there are a few categories that we're not able to capture. So things like durable medical equipment don't get included in our study. Indian Health Services doesn't get included. The VA doesn't get included. But by and large, we have the majority of healthcare spending in the state. And our analysis is able to incorporate $51 billion. Across that $51 billion, more is from private insurance than any other payer. So you can see that $23.6 billion is from private insurance, with the next largest being Medicare at $13.5 billion. If you look at the types of care, those are the different columns that we're looking at. So there's more spending and almost 50% of the spending on outpatient care. So all outpatient care fits into that ambulatory bucket with 24.6. Inpatient hospital care is at 11.5 billion. You can see they get smaller and smaller after that. And then the center of the matrix is, tells you how much each payer is spending on each type of care, and with the shading, the darker being where there's more spending. So the most spending is from private insurance on ambulatory care, and we can see that the second most spending is from Medicare on ambulatory care as well, and then really a huge amount also on hospital inpatient care from all of the payers, including out-of-pocket, which we capture at the bottom. Next slide. So this next one I think is a little bit more interpretable. Instead of just showing these totals, which is the $51 billion that we spend on health in Washington State, this is looking at either per capita terms, that's the top and the bottom rows, or per beneficiary. So just to orient you, that top left corner says $6,715. That is across the state, the average spending per person on healthcare. And if you go down one box to 10,498, that is the average spending that Medicare spends per beneficiary in our state. And next down is Medicaid. We spend just over $5,000 on Medicaid per beneficiary. And finally, private insurance is almost $5,000 per beneficiary. So I said earlier, that most of the spending, the largest bucket of spending was private insurance in our state, but in per person or per beneficiary terms, of course, we spend much more on the older population, Medicare, and to some degree, Medicaid. And again, we see the patterns here on how much is spent per type of care. Next slide. So this shows the growth pattern over time in the state of Washington. So again, our study spans from 2010 to 2013. And you can see where there is the most growth. We see growth from about 34 billion to 51 billion over the course of this decade. And I'll talk in a moment on some of the things that we attribute that growth to. But you can see on the left, these are the types of payers that have increased, and really all the payers have increased spending over this time period. And then on the right, we see the types of care that have had the increases, and really all the types of care have had major increases, with ambulatory care growing the most in relative terms. Next slide. Oh yes, go ahead, Leah. Thanks for jumping in.
Just a quick question on the per capita spending.
Yeah.
For the all payers, does that include uninsured too? Is that a population level or just the members within those insurance groups?
Yeah, so that bottom row of out-of-pocket spending is capturing the uninsured, and it's capturing deductibles and copays from the insured population.
Okay, so the all payer is really all,
It
it's,
really
it's
is
all
all payer.
residents.
Yes, exactly. Yep.
Great, thanks.
And one thing to just remind folks, I think there's, appropriately so, a lot of interest in out-of-pocket spending. The out-of-pocket spending is a huge portion of that is still the insured population, be through deductibles and copays. Really, the lion's share of that out-of-pocket spending. So this looks like the slide that you've already seen, but instead of now looking at per capita spending, this is looking at growth rates over time. And so again, the darker bars are just telling us growth rates, and the lighter bars are telling us age standardized growth rates. So essentially, if Washington had the same age profile in 2010 as it did in 2019, we see the growth rate would be a little bit smaller. But ultimately, if we want to compare ourselves to the other 50 states and the District of Columbia, then we see we're the 30th lowest, or the 20th highest would be another way to look at it. So a little bit on the higher side as far as growth over time. And again, I'll break that apart and some of the drivers of that in a moment. Next slide. So here's that kind of breakdown. And I think this is a confusing slide for people initially, but it's, can be quite powerful and a lot of information in here. So I'll try to talk you through it. So the different rows here are the different types of care that we analyze in our study. So again, on the top is ambulatory care, which includes all of outpatient. The next one is inpatient hospital care, and next is dental care, then retail pharmaceuticals, and so on. The dot is the increase in annual spending for that type of care from 2010 to 2019. So the dot for ambulatory care, the black dot for ambulatory care out by essentially 10 billion, says that the annual spending on ambulatory care increased by $10 billion between 2010 and 2015. So that's this major increase that we saw. The colored bars tell you in our world kind of how we've attributed that spending. What is leading to the biggest increase? And so for ambulatory care, we see that there's an orange bar that's going negative, which is a little confusing, but it just says that utilization changes for ambulatory care have actually led to reductions in spending. There's essentially fewer outpatient visits per capita after you've adjusted for age than before, than in 2010. And that's why it's a bar that goes to the left of zero. The really big green bar says that the majority of the increase in spending on ambulatory care is really revolving around the spending per visit. So the orange bar says, actually we spend less because of utilization. The green bar says we spend a lot more because of higher prices and more intensive visits. And then the blue and the pink really are collectively, that's demography. That's the age and the sex and the size of the population. And so we, of course, spend more in the state of Washington on health because we're just a bigger state than we were in 2010. And we spend more because we're an older state than we were in 2010. And so that's the pink and blue bar. But if we really want to think about resources that can be constrained or where there's opportunities maybe to slow growth, it's going to be those orange and green bars, with orange being utilization and green being the prices and the intensity of care. And so for most, but not all, of the types of care, but really the big ones, ambulatory care and inpatient care, we see that utilization has slowed down. That we use resources, again, after you adjust for the age of the population and the size of the population, we're using health resources less than we did in 2010, but almost uniformly, the prices have gone up. That's true for outpatient care, hospital inpatient care. That's true for pharmaceuticals, home health care visits, and for emergency department visits. Any questions about this slide? Really is an attempt to kind of start to explain why we spend more on healthcare each year, which I think can be an amorphous, kind of topic or problem, and tries to start to identify it. Patrick, go ahead.
Thank you. Is there any way to try and differentiate the reasons for a decrease in service utilization, for instance, utilization review versus somebody choosing to forego a procedure, perhaps because of cost drivers?
So that's a great question. Thanks. What we will be able to do in the future iterations of this is to look at this by disease, and I'll kind of show you that. And I think when you have a disease lens, you can and you can marry it with disease prevalence, you can start to ask the question of, is this, can we start to ask the question of why there's less utilization? So I think we're never going to get at a satisfying answer that is that granular of answering that question, Patrick, but I think some of the information we'll be able to provide will offer some hints. And so what I mean by that is, we'll make the same figure for diabetes, and what we'll look at is changes in utilization per diabetic. Now, we won't necessarily be able to say, why are diabetics using outpatient services less? But we will be able to highlight that it is diabetics, that specific disease, that we're seeing reductions in. And we can do the same thing for heart disease or cancer or any of the major disease categories. So we'll be able to fine tune it a little bit, but what we won't be able to do is back out and say, well, this was because of financial concerns, or this was because of access and geography. That will be out of scope of this study. Thanks for asking. Okay, next slide. So this, and I'll have a series of slides that kind of show these same sort of plots, but this allows us to kind of dial in and look specifically that in the increases of spending for different payers. And so this looks at the 4 payer categories: Medicare, Medicaid, private insurance, and out-of-pocket. Again, I remind you that out-of-pocket spending is not so much the uninsured, but it's really the amount of spending that is deductibles and copays. So right away, if we're interested in the state of Washington, we can look at Medicaid. We see here that prices are leading to increases in ambulatory and inpatient spending, increases in annual spending. We see that utilization of inpatient services has gone down. Those are bed days per capita. But the visits per capita for ambulatory care has increased. So Medicaid is essentially seeing an increase in utilization, where the population as a whole is seeing a little bit less. And then if we want to dial in on a specific type of care, like hospital inpatient care, we can see that really across the payers is this trend of fewer bed days per person in the state. And the reductions in utilization are generally more than offset by the expenditure or the price per bed day, or the intensity and price of care. So we can kind of pinpoint some of the reasons for growth for something like inpatient care, which is relatively uniform across the payers, or we can highlight differences like Medicaid spending having increases in utilization, whereas something like private insurance has reductions in utilization for outpatient services. Next slide. I'm keeping an eye on the clock, and so I'm going to go a little bit quicker because I don't want to cut us too short, but please stop me there. And as a reminder, the entire preliminary report is in the booklet. So this is a table.
David has his hand up.
Oh yeah, thank you, David. Thanks, Rochelle. Go ahead, David. David, are you there?
Apologies, double muted. There are 2 areas on the prior slide that really jump out, looking different than the others. And one is the dental visit area for Medicaid, and the other is out-of-pocket nursing facility costs. And in particular, looking at the Medicaid dental visits, the magnitude of those offsetting service price and intensity versus service utilization is $2 billion.
Yeah.
Separate effects that offset each other, essentially. That magnitude is surprising. And I'm curious to potentially know a little bit more about that, although recognizing we have limited time. And then the other one is the nursing facility side, the magnitude of those out-of-pocket service price and intensity reductions are really quite striking. Is there anything that you could say about those two areas in particular that account for those sort of disparate findings?
Yeah, thanks, David. You know, I don't have an immediate answer to that. I've looked at those and been perplexed as well. I mean, it is, you know, in many ways it's a small numbers problem, but you know, Medicaid dental visits isn't a small, you know, Medicare dental visits is small. Medicaid dental visits isn't so small. And I will show on the next slide that there's a lot of spending there. I can try to follow up on that because we do see, you know, this kind of knife edge kind of, you know, really extreme response on both of those two. So let me look into it. I don't have a quick answer for you.
Appreciate it. Thank you.
Yeah, thanks for raising it. So this is a breakdown by disease, and I just kind of hinted at this before. We see a lot of spending on oral disorders. Now, some of this is just the function of the way that we lump diseases together. And oral disorders includes a lot of things. It includes all your cavities, and also all the orthodontia, braces, and retainers, and also oral surgery. So there's, you know, a lot of money in this category. You can see, you know, ultimately on where the resources are coming from and where they're going. Next, below that is joint pain, which is essentially knees and hips. And below that is diabetes, and those estimates are in billions. Next slide. So these are some of the health conditions that have had the most growth. So again, this is just trying to describe where the growth is happening. You see joint pain, I just mentioned, is annual growth here of above 5%. And that is knees and hips. A lot of that is outpatient ambulatory surgeries and interventions. Anxiety disorders increased an enormous amount. This is pre-COVID, as a reminder. And like everywhere, we've seen major increases in spending on diabetes. So, next slide. This is starting to take those individual diseases and breaking them apart. And David, you know, your point about, you know, some of these kind of flip-flopping in a strange way is true for this diabetes chart a little bit, but I think here that it's a little bit clearer that there are major utilization reductions. It still feels a little bit like a knife edge, but I think there's, you know, for something as large as diabetes, we're capturing something here. But either way, this is really just meant to highlight that when we talk about different diseases and places for growth and spending in the state, you're really talking about very different things. And so diabetes on the far right has growth that is, you know, coming from a lot of categories. Ambulatory care has gone up, pharmaceutical spending has gone up, nursing facility care has gone up. Really all the major types of care, except for dental and emergency department spending, have increased for diabetes. Where something like anxiety and joint pain is it really is outpatient services, it's ambulatory care. And even between the two of them, you see a difference in anxiety is really increasing because of more utilization, whereas joint pain is increasing more because of the price and intensity of care. Next slide. So this is starting to break this down by county. Again, with an eye on the clock, I'll move quickly, but it highlights where there's the most spending per capita. Next slide. This is another way of looking at it. It's a little bit more wonky, but I think can be informative. On the x-axis is the age standardized spending per capita. So this is, you know, trying to create we know some counties are older or younger than others. So this is trying to compare apples to apples. So everybody's been age standardized to the population of the state as a whole. And then on the y-axis is the increase in spending over time. Again, that's age standardized. And so you can kind of see where we have current outliers in spending, Columbia and Garfield counties. And we can also see which counties are seeing the most growth in, again, after adjusting for population factors. Next slide. This is similar to the maps I showed before, but it highlights where there is the most spending per beneficiary. Again, it highlights some of the same trends, but also some divergent trends as well. We see parts of the state like the Southeast that tends to be expensive for most of the payers that we're looking at in per beneficiary terms. Obviously not the most populated part of the state, but we see a lot of spending there and in per beneficiary terms. And in terms of Medicare, we see, more on also on the west side as well. So, and we can see the Olympic Peninsula in particular for private insurance stands out. Next slide. This is my last slide. And it just starts to highlight the ability to compare at the county level the spending in each county to the all-state average. So just to interpret this, before when we were looking at these similar figures, we were looking at changes across time. The comparison here is, if we're looking at Adams County in the top left, is how is Adams County spend health resources different than the rest of the state or the average county within the state. And so you can see Adams County spends less on ambulatory care per capita and spends more on inpatient care per capita. You can see that that's driven by utilization in the case of inpatient care, and for ambulatory care, it's driven by a number of different factors. And one last slide takes us, I think, back to the questions. I know we are running, we're about 3 minutes over on time. I think we started a few minutes late, but wanted to just give an opportunity to get any initial or quick pieces of feedback that might be provided to improve the current report or long-term suggestions for the report. Justin?
Yeah, thank you. So I work in an urgent care clinic setting, and in looking at some of these numbers and statistics, which are really helpful, is there a way that we can look at ambulatory care a little bit more closely? Because I know, there might potentially, from based on the numbers, it looks like there might be an inverse relationship between the utilization and intensity or cost of care aspect. I know that, when we look at ambulatory care, that's very, very broad. If it's specifically a designated primary care provider for that patient, or for patients versus, say, in a convenience care or urgent care setting where there might be high utilization and also high cost and high intensity of visits. I'm not sure, is it possible to stratify that out a little bit more?
Thanks, Justin. That is a piece of feedback we've heard before. If you look nationwide, our ambulatory care budget kind of bucket is 43%. So it's enormous. And you correctly identified that captures a lot of different things. That's, outpatient rehab, that is ambulatory surgical centers, that is urgent care, like you mentioned, and it's primary care. So a lot of different things. And I think that is something we aspire to do. If it'll happen before our next report at the end of this calendar year remains to be seen, but we're definitely trying to do that and kind of looking at the data to see how that might be able to be done. It certainly seems possible, so it's something we hope to do. Hunter?
Yeah, thanks. And first off, just really appreciate all the different slides, very, information dense, which I really appreciate.
Right.
And I really just kind of echoing the previous kind of comments, in terms of trying to drill down ambulatory, and I know we can try to cut that in a number of different ways, but I do think one meaningful way to look at it would be to see if we could differentiate by, procedures, like interventions, because especially if it's, picking up the ambulatory surgery, maybe not necessarily, you may have limitations on the site, maybe not as easily be able to differentiate between a freestanding ASC and the hospital outpatient, but at least having the overall procedures, because I think that could also speak to the different inverse relationship between service utilization, especially inpatient, and then the higher intensity on the ambulatory side. So I just think, I know, many different things, but in terms of priorities, that probably would bubble up to the top.
Great. Thanks, Hunter. I am less optimistic about getting down to a service level in the next few months, but I think it is so on our mind. And I think being able to, you know, if you're looking at services and intervention level, you can actually differentiate price and intensity, which is in our current figures, you know, gets kind of bundled together. But of course, differences, you know, if we're spending more because of prices versus spending more because of intensity, those are really different things and have different policy ramifications. So I think your idea of going towards more of a service level is exactly what we're thinking about in the long run, because it does allow us to, you know, have such a more granular perspective on what's going on. So yeah, thanks.
Great, appreciate it.
Alan?
Yeah, hey, we appreciate your time and walking us through this. I think the slides on their own are one thing, but the narrative is an important element to kind of understand the overall story. If
Yeah.
we do have feedback, can we reach out to this team on what's the process look like there?
So I kind of defer to Rochelle on that. I think we are looking for feedback, and that's what we want. And so but I don't know how that gets funneled first to the HCA and then to our team. But maybe Rochelle or someone on the HCA side can mention that.
Yeah, thank you for the question. So if you have feedback, then you would just respond to the advisory committee inbox for the advisory committee that you are a member of. So either the healthcare stakeholder advisory committee inbox or the data issues, and we will respond to you that way.
Thanks, Jonathan.
All right, thank you.
Great. And the last steps are, you know, really, and this is even a little out of date, April and July is, you know, almost here essentially. April's here and July is soon to be here. But we're in the process of incorporating the APCD. That's ongoing work. We're really excited about it. And then as we move into the fall, we hope to essentially build upon this to take on additional projects related to standardizing these estimates, further decomposing the changes and the differences, as well as just continuing to look at the trends in spending and utilization. So thanks very much for your time.
Thank you, Joe, for the presentation. Next, we'll hear from Sherry L., Health Economics Research Manager here at the HCA, and she will give us a provider reporting overview.
Can you give me an ability to share my screen?
Just one moment, we're switching screen share.
Thank you. All right, thank you, everyone. Today I'm going to present very briefly and provide updates on what we are doing on with regards to provider reporting. And then we're also going to give just like a very high level overview of the methodologies that we will use for the provider reports. And then I will also provide details on how and when you can provide feedback for these methodologies as well as provider reporting. So on the first item of my presentation, we have conducted the very first provider reporting webinar on June 6th. So providers have attended this one, and we're able to provide them an overview by giving them a template on the provider report that they will be receiving sometime this July for the data that was collected in year 2022. So we collected for the data call in 2022, we collected 2017 to 2019 data. And then we also expect to have another report to share the provider performance from the 2024 ongoing data call, which aims to collect 2020 to 2022 data. We also provided information about public reporting with regards to comparing provider performance versus benchmark growth. And that would start with 2022 data, which is the start of reporting year that has the first set benchmark growth. So in the webinar, we said that we will compare the confidence interval of the growth rate of the adjusted total medical expense, or the TME, per member per month to the benchmark growth rate. So very briefly, the benchmark growth was set by the board in 2021, and it's a combination of the weighted average of the growth rate of the median wage rate, as well as the per capita GDP growth rate here in Washington. As for the adjusted total medical expense, PMPM, just a reminder that this is the sum of the age and sex risk adjusted truncated claims PMPM plus the unadjusted non-claims PMPM. And then we talked about in the webinar how we adjusted for age and sex risk. And then we also talked about how we truncated claims to be able to get the adjusted total TME PMPM. And then for the confidence interval, which we'll discuss in very briefly in the next slide, we talked about how we pull the different variances that carriers submitted in order to be able to get a singular variance for each provider. So in the next slides, I'm going to just give an overview of these different methodologies, but in an email that we will send in the tab of our packet in tab 5, we have very detailed methodology on how we did these calculations. We also have an Excel file for these different calculations that you can go through. It provides an example and the detailed steps on how to calculate all these calculations. So on method 1, which is truncating claims spending, this means that we do not include some spending that exceeds a certain threshold, and that is to ensure that a very spending from very few high-cost individuals doesn't affect the cost growth of a provider or a carrier. And this threshold was set such that the total amount of per member spending above threshold is about 5% of overall market spending. This is based on an on-point analysis on the 2019 APCD data. And based on that table, you can see that the truncation threshold for commercial, Medicare, and Medicare markets are those numbers. And if we truncate on a per member basis, and based on this data, less than 1% of members have truncated spending, so it's not a lot. So again, more details and examples are in the technical manual. We have provided an example in the technical manual so providers can understand how truncation was done in the data call. For the second method, which is to adjust truncated claims based on age and sex, and this was decided by the board in the previous meetings. Well, we have detailed documentation on this one in the tabs, as well as some sample calculation that provides very highly technical provides highly technical information on how this one is calculated in our provider reporting. So in summary, the adjustment is based on 2 weights. One is on age and sex risk factor weight, and the population weight of each age and sex combination. So the first weight is the age and sex risk factor weights, and this is calculated by getting the ratio of the PMPM for each age and sex category or sector, and get the ratio to the overall PMPM of the insurance category. So when we calculate the cost growth, this risk factor weight is fixed at the baseline such that this factor weight does not influence the cost growth of a provider. But what does influence the cost growth is the population weight of each age and sex band. So that if there are more members in age and sex band with higher PMPMs for a certain year, then growth is adjusted downwards. And if there are more members in age and sex bands with lower PMPM, then growth is adjusted upwards. So basically the adjustment is to make sure that the cost growth reflects what would cost be if the risk profile is similar to the general population in that particular insurance category. The third methodology that we use in providing performance reporting is pooling of the variances. And this is because we get different standard deviation from carriers, because carriers are the ones submitting the data for all the providers. And so we need to pull this standard deviation to get a single variance, and then this serves as an input to calculate the confidence interval of the growth rate. And then we feed into like the fourth methodology, which is to calculate the confidence interval of the growth rate of the adjusted TME PMPM. Again, more details are in the Excel file. Okay, we will send the Excel file, but this one is in tab 5, which is not in an Excel file format, but the Excel file format should be more friendly and convenient. So in summary, what we do in this one is that we get the risk-adjusted truncated claims spending PMPM, which we talked about in the previous slide. And then we sum it with the non-claims PMPM to get the adjusted TME PMPM. Then we get the pooled variance as an input to calculate the confidence interval, which is specifically the 95% confidence interval, to get the lower bound and the upper bound, and the point estimate should be in between the confidence interval. Then we get this confidence interval of the cost growth and compare it to the benchmark. And so if the lower bound of the confidence interval is greater than the set benchmark, then we said that the performance or the cost growth of the provider is said to exceed the benchmark cost growth. And again, like, I know this is like very quick and very brief because I only have 10 minutes, but more detailed documentation on this one is in tab 5 of the meeting packet. And we welcome any feedback on the methods as well as its documentation. We'll email this separately, so it's more convenient for you to read. But if you have feedback, kindly email it to this email address on or before June 26, 2024. Thank you very much.
Thank you, Cheryl. Next, I would like to welcome any public comments. The 6th tab in the committee book contains information related to public comments. It doesn't look like we have public comments at this time, but if you would like to provide public comment, please raise your hand. Then we will call on you. And when you're called upon, you will be invited to join the meeting as a panelist. To enable speaking, please join the meeting as a panelist and unmute yourself. Please state your name and your affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has an opportunity to speak. If you are also welcome to provide comments in writing via email at any time. Just checking the list right now to see if we have any public comments. If anybody would like to have a public comment at this time, please make sure you raise your hand so we can call upon you. I don't see any hands raised. I will just give it one more glance over before moving on. Okay, that concludes public comment. It doesn't look like we have any hands. Thank you all for attending today's joint committee meeting. That brings us to the end of our meeting today. The recording and summary of this meeting will be posted shortly on our website. Thank you again to all our presenters and for our committee members for attending. For our healthcare stakeholder committee members, thank you for attending both sessions today. Our next committee meeting will be held on Wednesday, August 21st. For our data issues committee members, please stick around. Since we're a little over time, we're just going to jump straight into the next meeting. Thank you all, and this concludes today's meeting.